In Ghana, more women are reaching clinics than ever before. Health insurance has expanded. By every visible measure, things have improved. And yet, Ghana's maternal mortality rate is still roughly 4 times above the global target. This isn't just a statistic. It's a question that defies logic. And the answer is not what you think. She did everything right. Every antenatal appointment, saved money for transport, arrived at the facility before labor became complicated. A few hours after delivery, the bleeding that should have slowed hasn't. The facility does not have blood for transfusion, not because no one tried, but because the one thing needed in that exact moment was simply not there. She reached care, so why wasn't she safe? This isn't a rhetorical question. It points to something far deeper than just access, something that more facilities and better insurance coverage have not and cannot solve. To truly understand it, you have to go further back, much further back than the delivery room. Start with distance, but not the way you usually think about it. Distance isn't just kilometers. Distance is time. A woman in a rural community goes into labor. Everything is normal. Then suddenly it isn't. The nearest facility can't manage the complication. She's referred. Transport is arranged. The road is what it is. By the time she reaches a facility that can handle what's happening, the emergency is no longer early. The gap between when a complication begins and when the right care is available, that's where outcomes are often decided. Now hold that image and add something even more critical to it. More than half of pregnant women in Ghana are anemic at the time of delivery, over 51%. Anemia means the body has less capacity to handle blood loss, a narrow margin for error, a slower recovery window. But anemia doesn't begin in the delivery room. It begins in households where food costs compensate with rent and school fees, in communities with repeated malaria exposure, in diets shaped by what is affordable, not what is sufficient. So when a complication happens at delivery, the system isn't responding to a healthy body under stress. It's responding to a body that has been under pressure for months. The emergency did not start at the hospital. This prolonged pressure isn't just felt by the patient. Picture a health worker at a regional facility. She has been there long enough to know the rhythms of the system. She knows which days the blood bank has supplied, which roads flood during the rain, which referrals will arrive late, and what to have ready. She has built informal systems around formal gaps. She's skilled, she cares, but she's compensating every single shift. And one individual effort is the main thing holding a system together. That system is already fragile. This isn't a story about one person. This is a pattern. This pattern of fragility brings us back to a broken assumption. We think of access as the finish line. If a woman can reach a facility, the problem is solved. But access and outcome are fundamentally different things. A facility without consistent electricity doesn't function the same. One without blood supply doesn't function the same. And where 3 staff carry the load of 12 doesn't function the same. So the system improves. New buildings open. Coverage numbers rise. But if the inputs inside those facilities are uneven, the outputs will be uneven too. More access to an under-resourced system is progress. But it's not the finish line people think it is. This realization forces a midpoint reset. Most explanations of maternal mortality focus on what happens inside the hospital. The staff decisions, the equipment failures, the response time, and those things absolutely matter. But they missed something crucial. The nutrition, the road, the budget line that never reached the blood bank was already shaping what was possible. We are asking the delivery room to absorb a chain of failures it did not create. Let that land. If the delivery room is a symptom, then what is the cause? It's a chain. Nutrition during pregnancy, anemia status at delivery, distance to the nearest facility, road and transport infrastructure, facility capacity, staff to patient ratio, blood supply, response speed when something goes wrong. Each link connects to the next. A woman who is anemic and lives far from a well-resourced facility isn't facing two separate risks. She's facing one compound risk because the chain pulls together. And the system as it currently operates often addresses each link separately. Nutrition programs, transport subsidies, new facility construction, staff training, these are real interventions, but they are frequently designed and funded without full accounting for how they interact. A transport subsidy doesn't help much if the destination facility can't manage a complication. A well-staffed facility doesn't fully compensate for a body that arrived already depleted. The system holds until it doesn't. And when it breaks, we focus on the link that snapped last, not the ones that were already under strain. This is the hidden mechanism at play. The issue is not that Ghana lacks care. It is that the system absorbs risk at the wrong end. Let that settle. Most of the structural weights fall on the final moment, the delivery room, the referral call, the nurse making a decision with what is available. But the conditions that determine what was possible in the room were set months earlier. In a household budget, in a road that added 2 hours, in a funding allocation that never reached a blood bank, in a policy that opened a door the system behind it wasn't ready to walk through. We treat maternal death as a delivery room event. It is usually the last point in a much longer process. So if the system absorbs risk at the wrong end, how do we shift that burden? When Ghana's affirmative action policy aims to increase women in decision making, there's a specific logic worth naming here. It's not just about fairness of representation. It's about which questions get asked before a budget is finalized, which gaps get named before the infrastructure decisions are made, which accountability systems get in rather than added later. When people who have lived inside a system are designing the response to it, the change becomes visible earlier, not automatically, not through representation alone, but the conditions for asking the right questions, they fundamentally change. And so we return to her. She did everything she was supposed to do. She showed up. But showing up only matters if the system she showed up to had what it needed to help her. And that depends on decisions made long before she arrived. In budgets, in road design, in supply chains, in who was in the room when the policy was written. So the question is not just why are mothers still dying? The question is, at which point in the chain are we asking the system to compensate for everything that came before it? And who decided that was acceptable?